Good afternoon, everyone. Welcome to this afternoon's oral session as part of the 9th International Festival of Public Health. I've already introduced myself to a few of you, but for those of you that have just arrived, I'm Dr. James McConnell. I'm a lecturer in public health here at the University of Manchester, and I'm chairing this session alongside my colleague Mick Camratti, who some of you have also been introduced to. So this afternoon, we've got 8 fantastic presentations, and we'll cover a wide range of topics, which include infection prevention, improving COVID-19 vaccine uptake, and the social determinants of homelessness. So I'm sure that all of our presenters are ready to go, but before we get started, I've just got a couple of housekeeping points. So firstly, just to remind you, this session is going to be recorded so we can all review it later. Please try and ensure that you're on mute if you're not talking so that we can hear the presenters. And also these presentations are scheduled to be 10 minutes in length. So if you could try and keep it to 10 minutes, that'd be great. And then we're going to try and plan in for 3 minutes of questions after each presentation. But we'll just see how the timings go and if we need to change and maybe have questions at the end. But for the moment, it'll be a 10-minute presentation with 3 minutes questions. So without further ado, we can move on to our first presenter, who is Carl Diekman from the Health, Education and Wellness Rotary Action Group. And I've just been speaking to Carl and complaining about our weather here in the UK, and he told me that it's 40 degrees where he is. So we don't really have anything to complain about. So over to you, Carl.
Okay, thank you very much, James. And let me get my share screen going here and get our program up. There we go. Okay, well, I'm going to try and make all these technologies work today, but I would like to thank the University of Manchester for this creative approach to continuing this especially important educational opportunity during the incredibly challenging period of COVID-19. I am Carl Diekman, coming to you today from sunny and right now ridiculously hot and dry California, USA. My presentation is on behalf of the Health, Education and Wellness Rotary Action Group, otherwise known as HURAG. HURAG is comprised of hundreds of Rotarians from all corners of the world, and we focus our energy and resources on a growing list of health issues, including oral health and nutrition, tuberculosis, autism, cervical cancer prevention, and much more. So for a full understanding of my presentation, it is important for you to know that healthcare was not my profession, but I do have experience as a paramedic. I manage ambulance operations because that's a function of the fire service in much of the United States. However, service has always been my interest. And after a successful career as a chief fire officer, I began working on humanitarian projects in retirement. Over time, my humanitarian service interests have increasingly focused on cervical cancer prevention. The photo on the left is from one of many presentations that I made over a 4-decade career in the fire service. The photo on the right is from our project in Nicaragua, and it is of students and part of the team that I put together to teach low-resource techniques for examining women and treating for conditions that lead to cervical cancer. Those techniques include VIA and cryotherapy. The clinicians, teachers, and students are in the front, and you can see me way in the back. This project lasted more than a year, and our team of 50 healthcare workers trained over 20 clinicians, outfitted 5 clinics, and examined more than 1,000 women for HPV lesions that cause cervical cancer. Looking at this slide, you can see that my career in the fire service began in 1966, concluding in retirement in 2006. Although most of my career was as a chief fire officer, I had ample opportunity to serve in a variety of capacities early on. Looking at the column on the right, you will see how my interest in humanitarian service and my career overlap, starting with my entry in Rotary in 1982. My real breakthrough on international humanitarian service came after my professional retirement, when in 2008, I participated in a polio immunization drive in Agra, India. That trip cemented my interest in health-related issues. By 2013, a group of us led by my good friend and fellow Rotarian Sheila Hurst created HURAG to sustain an oral health and nutrition project in Kenya, known as Kenya Smiles. The premise of forming HURAG was to build a portfolio of projects that could be easily replicated. Backing up just a little bit, I want to draw your attention to a literacy project that I organized in Livingstone, Zambia in 2011. This slide shows how Rotarians in California and Livingston worked with a local school district to deliver a dictionary to every fifth grade student in the Livingston School District. I am proud that our team placed a dictionary in the hand of each of the 5,000 students. Well, one project led to another. Well, got to get them going the right direction. Sorry about that. So in this project, well, earlier I mentioned our oral health and nutrition project, Kenya Smiles. In this project, we worked with a large team of oral health professionals and educators in Kenya and California to improve training for dental professionals in Kenya, provide dental equipment to clinics, provide education to children on oral health, and much more. Kenya Smiles served dental professionals and dental students along with tens of thousands of school-age students throughout Kenya. Rotarians from California and Kenya worked together, even supported the opening of a bakery in one of Nairobi's slums. Much to my joy, you can see in the photo on the right that we even found time for students to teach me a local dance. The project was important because California and Kenya are roughly the same size and population. Yet in California, we have roughly 34,000 dental professionals, and in Kenya, the dental professionals number in the hundreds. You can read more about this project on our website, hurag.org. Well, as I previously mentioned, this work all led to the creation of HURAG. So by this point, I was on a mission to find that one public health project that I could immerse myself in. And that led me to the 11th International Conference on Urban Health held in Manchester, England during March 2014. I attended this meeting with the intent of identifying a project that I could work on in a meaningful way. It turns out I did not find that project at this conference, but it did open my eyes about how I could find that project. In the meantime, HURAG was starting to develop its portfolio of interests, and there were several influences you can see on this slide. My attendance at the Urban Health Conference was a significant influence because it gave me the tools to talk about projects in a more expansive way. Our experience with oral health and nutrition through Kenya Smiles was also an especially important influence. Another key influence was our health fairs and medical missions group, which merged with Kenya Smiles Group to form HURAG, a referral of the American Cancer Society to HURAG by the General Secretary of Rotary for the express purpose of engaging in cervical cancer prevention was a crucial influence. This referral from Rotary to HURAG and my work on the Nicaragua project cemented my interest in cervical cancer prevention. As I have mentioned, cervical cancer prevention is a key influence and current activity for HURAG. But it was a confluence of the project in Nicaragua, Rotary's request to work with the American Cancer Society, and our invitation to the Cervical Cancer Action Investing in Cervical Cancer Prevention 2015-20 conference in London that made cervical cancer prevention a key element of HURAG's mission. Now, in addition to my role as a cadre technical officer and member of the board for HURAG, I serve as the lead for its cervical cancer prevention effort. Today, HURAG has a team of Rotarians, including physicians, educators, and other interested individuals working to raise awareness among Rotarians about the opportunity to alleviate suffering for women and their families because of cervical cancer. And because of Rotary, our reach is global. One of the ways we accomplish our mission is through the publication of educational materials tailored to Rotarians. This guide to cervical cancer prevention that we have published is a tool that Rotarians can use to help guide them as they design cervical cancer programs in their communities. Another way HURAG meets its mission is through outreach, both in Rotary and beyond. A good example of our outreach was my representation of HURAG in the consultation process for the recently adopted World Health Organization policy to eliminate cervical cancer as a public health problem. The photo in this slide is of the consultation meeting that I participated in at the Pan American Health Organization in 2019. I am sure that you are aware that approximately 300,000 women needlessly die of cervical cancer annually. While most of these deaths are in developing countries, they occur in unacceptable numbers, even in the United Kingdom. I spend a good deal of my time traveling to places around the world, raising awareness among Rotarians and helping them design projects. Of course, 2020 and 2021 are exceptions. So most of the attendees at the International Festival of Public Health are rightfully at some point in their public health career. What I hope is that you have gained from me today is that there are endless numbers of people who want to help you improve the quality of life in your communities. Please make sure to help them find you. Thank you all very much. Back to you, James.
Thank you very much, Carl. That was really enlightening. I'm really interested in the work that you did in Nicaragua, where you were there personally when the training was done. So what you're doing was trying to improve awareness of the techniques that could be used to reduce to diagnose early on, so to diagnose HPV. Is that correct?
Well, yeah, it's a little more complicated than that, but the primary purpose of that was about a 3-year project that involved an educational process and developing a team. And what we did, we brought in a firm that teaches the proper techniques for examining women for the lesions that cause cervical cancer. Virtually 100% of cervical cancer is caused by the HPV virus. And while we have vaccine, there's a whole that's a whole different issue. But this project was to teach people, clinicians, how to perform a simple technique known as VIA, which is visual inspection with acetic acid table vinegar. And then if they discovered a lesion, it could be removed, usually with cryotherapy. So many women, about 70%, get screened out because no issue. Some women need treated and some women are found to have cancer and need to go further. And so we do our training in a 3-step model: train and examine and teach, then give them a period to work, go back and evaluate, train and technique, and do that for 3 successive visits. And then the people are certified in whatever procedures that they have.
And is that a technique that could be rolled out in other places? So you're saying that particularly in developing countries, the diagnosis rate is low. So is that something that could be transferred to other?
And that is actually one of the goals of the World Health Organization policy. Although the techniques have changed, newer methodologies of HPV genetic testing, high-speed testing are now available, so that reduces the number of physical examinations that need to be made, a lot of self-testing, and the technique of cryotherapy has now evolved to thermocoagulation, which is a much less expensive and bulky technique. You can carry the tool in a simple little suitcase, has a battery, as compared to carrying a several 100-pound bag of the proper gas and all the tools that go with it. So it's evolving, but there are different groups of people, and the real issue is making sure that the local clinicians are properly trained, the women in the community are motivated to become examined, and they're examined on some periodic basis so that you can interrupt the disease or interrupt the process of the disease before it happens. I don't know. Hopefully that's a good enough explanation.
Yeah, very much so. Yeah, it's really nice to hear. Thanks so much, Carl. That was really enlightening. I don't know if anyone else has got any other questions. If you can't think of one right now and you want to write one in the chat, then feel free. It's there for you all the way through this session. So I think now would be a good time to move to our next presenter. I think I've got down Andy Mapala, but I can't see Andy in the list of attendees, unless you're there, Andy. If you shout if you are. Okay, I'm not sure we've got Andy. So that being the case, I think if we move on to the third presentation on the list, which is Dahlia, if that's okay. So yeah, Dahlia I've been speaking to her before. She's in Manchester, so she's also at the University of Manchester. She's going to talk to us about hearing care for all. So go ahead, Dahlia.
Okay. Good afternoon, everyone. I'm Dr. Dahlia Tsimbida, based in the Institute for Health Policy and Organization at the University of Manchester. Welcome to this presentation today that has the title Hearing Care for All Virtual Gallery, Raising Global Awareness Through Art in the Time of Pandemic. I'm going to talk to you today not only about an important public health issue, but about an important part in everybody's life. I'm going to talk to you about hearing. And hearing is important because hearing connects us. We humans are made for relationship, and hearing, for those not natively deaf and fluent in sign language, is central to the sharing of emotions and ideas and happenings. Hearing loss is a major global health challenge and the most prevalent sensory disorder. The World Health Organization estimates that today over 466 million people live with disabling hearing loss. And unless action is taken, the number could rise to 630 million by 2030 and could cross 900 million by 2050. Hearing loss is far beyond a sensory disorder because hearing loss has many physical, social, cognitive, economic, and emotional consequences and affects the quality of life. Acquired hearing loss has been labeled as something which is more likely to affect the elderly. However, our research in the Institute for Health Policy and Organization at the University of Manchester shows that our focus should not simply be on the age of older adults, but on factors which impact on people earlier in life, which, if modified, could reduce hearing loss in older age. Hearing deterioration is a lifelong process, but not an inevitable result of aging. And understanding this process is an essential step in addressing the global burden of hearing loss. Tackling hearing health inequalities throughout the life course could improve the population's health, maximizing the opportunity for healthy and active aging. To promote this novel approach, I organized the Hearing Care for All virtual art gallery. The aim was to engage the general population and policymakers and promote hearing health during the life course. The virtual art gallery was organized on behalf of the Institute for Health Policy and Organization with the generous support of the World Health Organization, the World Hearing Forum, and the Coalition for Global Hearing Health. The World Hearing Day is an annual global advocacy event and the largest awareness campaign with calls for action to address hearing loss and related issues. Hearing Care for All gallery was one of the 52 selected activities from a total of 133 applications submitted globally for a World Hearing Day Small grant. The art gallery reached a global audience, featured 45 photo entries, visual art and poems from 15 countries: United Kingdom, Greece, Italy, Spain, Belgium, Poland, South Africa, Kenya, Namibia, India, Rwanda, Uganda, the Philippines, Australia, and Mexico. Today, over 1 billion people are at risk for hearing loss due to unsafe personal use of portable music devices. And the risk of permanent hearing loss arises from repeated, regular daily exposures to high sound levels. The art gallery highlighted public health messages around the hearing loss prevention and hearing health promotion, clarifying that the noise-induced hearing loss can be prevented to a large extent by reducing exposure time and levels of exposure to noise. These public health messages echoed the messages of the WHO World Report on Hearing, which emphasizes that the functional ability of people is not maximized unless individuals have a good hearing, and a life course approach in hearing health is necessary to tackle the hearing health problems as early as possible. Nearly 3,000 people visited the art gallery, and the online activities reached over 18.5 thousand people on Twitter. Creative activities engaged several audiences and challenged negative ideas about the hearing loss in older age. Utilizing art to communicate encouraged people to engage visually and interactively with the virtual gallery project. The case of hearing loss, where negative stereotyping persists, the creative dissemination provided an opportunity for accurate information to be reported in engaging ways that can help create dialogue and change public health perceptions. The Hearing Health for All virtual gallery and the Institute for Health Policy Organization were recognized by the World Health Organization, who congratulated us for the activities. And you can see more and enjoy the interactive experience that the virtual gallery offers by scanning the QR code in this slide. All entries are featured in the Hearing Care for All gallery, which is, as you can see, amazing and sunny, as a VIP visitor commented. If you have not already, please visit the art gallery, and remember that it's really important to protect our hearing while we are young, so as to enjoy longer and healthier lives. Thank you very much, and I'm happy to respond to any questions you may have.
Thanks so much, Dalia. That's amazing. I really like the idea of using visual art to engage people. And I've got a specific question about, so you're using it to promote knowledge. What do you find that the general kind of baseline knowledge of people in the public is about the risks to their hearing, and how likely they are to induce hearing loss with exposure to loud noise, at younger ages? Is this something that's like a gap in people's knowledge?
Yes, we have identified that there is a misconception that the hearing loss is something that refers only to older people. So I tried to challenge this perception and show that this is actually an issue that can be prevented during the life course. So showing several photos with occupations that have an exposure to high noise, so that this is something that we can prevent, and it's not something that we can wait until we are too old to address and go to further address and identify. So it helped, and the platform gave the opportunity to have a dialogue, a chat dialogue. So I had the opportunity to respond to people and to explain several misconceptions.
So it's interesting that you mentioned, the difference between occupational exposures and maybe like kind of lifestyle exposures, because obviously occupational exposures, they're quite well monitored, aren't they? Because in the workplace, they're really careful about what, the sorts of noises you can hear. I think quite a lot of us now in our daily lives are guilty of wearing the in-ears, maybe using them a bit too loud. I know for certain that I listen to my music too loud sometimes, and I know that's definitely a risk factor, especially with all of us using headphones all the time nowadays. So yeah, it's really good that you know that you're putting that information out there that you need to be careful when you're young.
Yeah. Yeah, sure. And it's really important because many people don't take preventive measures and they just wait until it's too late, and then they label it as age-related hearing loss, which is wrong. So we try to challenge these misconceptions and raise awareness about this very important public health issue.
Thanks very much, Dolly. Does anyone else have any other questions for Dolly? If you think of anything as we go on, feel free to post things in the chat. So the next on my list, we have Prevalence and Risk Factors of RAD-related presenteeism by Huawei from the University of Manchester. So Hua, if you're there, give me a shout. And if you're not there, I can move to the next person. Okay, so Amy, I'm afraid you're up. So our next speaker is Amy Arnold from East Sussex Healthcare NHS Trust, and she's going to be talking to us about COVID-19 vaccine hesitancy. Thanks, Amy.
Yeah, I'll just share my screen. Great, has that worked?
Yeah, great, thank you.
Wonderful. Where's that? Okay.
Perfect.
Great. Yep. Hi everyone. My name's Amy. I'm a Foundation Year 2 doctor, so based in East Sussex NHS Healthcare Trust. And the project I'm going to be talking about was when I worked with the East Sussex Public Health team. So it was a placement I did for a few months as part of my training. So the project I'm talking about is looking into increasing uptake of the COVID vaccine in the local authority of East Sussex. So we used an evidence-based approach to look at why uptake was lower in certain groups of people and geographical areas, and looked how to increase the uptake. Sorry. So as a background, as everyone's aware, I'm sure, so in January this year, the government published the UK COVID-19 vaccines delivery plan. So the outline of the plan had the aim to protect the largest number of at-risk people to COVID-19 in the shortest possible time, while reducing pressures on the NHS, preventing hospital admissions. Historically, the UK does have a really good sort of level of vaccine delivery. However, we know through immunisation programmes in the past and general health inequalities that there are large disparities in vaccine uptake across the UK population. So when I was working with the East Sussex Public Health team in March 2021 this year, I started a project looking at how we can optimise uptake of the vaccine, specifically in the population of East Sussex. So as a background, anyone that isn't familiar with East Sussex itself, it's east of England on the coast. It's quite a large county. So the public health team of East Sussex is actually responsible for a very large population and a large geographical area. So it's split into 5 what we call lower tier local authorities. So there's Eastbourne and Hastings on the coast, which are the urban areas. And then there's sort of Lewes, Wealdon and Rother, which is more rural. So East Sussex covers a very large area. So when looking at how to increase uptake of the vaccine across that area, it's quite complicated, thinking about people living in sort of urban versus rural areas and lots of different factors to consider. So the main aims of the project was to understand why vaccine uptake is lower in certain areas of East Sussex in particular. So then to increase the uptake in line with the national average, because when we started this project, there wasn't a target of percentage uptake to reach. It was more just how can we keep uptake of the COVID vaccine, continuing with the vaccine delivery plan in line with the national average. And also, most importantly, to reduce health inequalities by improving uptake evenly across East Sussex. So there's always going to be higher and lower levels of uptake. So rather than just looking at the average, wanted to see where in East Sussex was lower, and looking at places that we know and population groups that we know that are already negatively impacted by health inequalities to prevent the vaccine also being an issue as well. So the research, first of all. So this paper was really interesting. It's called A Practical Taxonomy for the Determinants of Vaccine Uptake, and it's published in Vaccine Journal. So it basically created a way of categorizing reasons for why people don't get any vaccine in history. And it categorized it into the 5 A's. So these are the 5 A's. So access, affordability, awareness, acceptance, and activation. So this is a good summary into why people don't get the vaccine. So first one, access, so just the ability to be reached by or to get vaccines. Affordability, obviously with the NHS, affordability shouldn't be a factor, but people would have to maybe take time off work to get the vaccine, or people might be concerned that if they get ill from side effects of the vaccine, they won't be able to go to work the next day. So that's a factor to consider. Awareness, so the actual knowledge of the understanding of the benefits and risks of vaccines and the fact that they're available and that we even need to get them. So acceptance is a key one. So that's to do with kind of hesitancy and maybe people's sort of personal beliefs or fears or reasons why they don't believe the vaccine is appropriate to get. So acceptance is key. And then the last one, the fifth A, is just the degree to which people are actually sort of nudged towards getting the vaccine. So activation, so people might have good access, they can afford to be able to go, they're aware of the vaccine, they accept that they need it, but they just haven't quite gone to get it yet. So it's a good sort of summary of reasons for low vaccine uptake. So we then looked into sort of national reasons for reduced uptake of the COVID vaccine. So this is in March, the ONS did an opinions and lifestyle survey, and the sort of three key points that were highlighted for reasons of low uptake. First one was age. So younger people reported they'd be less likely to get the vaccine. Second key point in this survey was ethnicity. So 44% of Black or Black British adults reported vaccine hesitancy compared to only 8% of white adults. And another key factor in this survey highlighted that deprivation is a key factor for reduced uptake. So the survey actually showed that adults living in the most deprived areas of England were more than twice as likely to be hesitant about getting a vaccine than people in the least deprived areas. So that was very key. So then narrowing down into the East Sussex population. So East Sussex actually has quite a notably older population than England in general. 26% of people are over 65 compared to 18% in England. And looking at ethnicity as well, interestingly, there's a larger white population in East Sussex compared to people from minority ethnic backgrounds. So that's good to know when we're looking at how to target people to increase the uptake. There's actually a much smaller population of people from minority ethnic backgrounds in East Sussex. But interestingly, deprivation, the 22 sort of neighbourhoods in East Sussex out of the sort of hundreds when you narrow them down, that are among the 10% most deprived neighbourhoods in England. So LSOA, as I've just put at the bottom, is a lower super output area. So it's a geographical area with a population of about 15 people. So that's about 30,000 people in East Sussex. So in the 10% most deprived areas of the UK, or in England, sorry. So as a summary, the East Sussex population is notably older. There's fewer people from minority ethnic backgrounds, but there's a significant number of people living in high deprivation. So that helped to sort of work out the people in terms of increasing uptake likely would be people in areas of deprivation. So then analysing some data. So the East Sussex COVID-19 vaccine uptake data published in March was what we're going to base the action plan on. So it showed us that there was particularly low uptake, looking here in Hastings, out of the 5 sort of lower tier local authorities, was much lower than the more sort of rural areas compared to the national average. Also looking at ethnicity, the data showed that people from minority ethnic backgrounds did have a low uptake as expected. And also looking at deprivation, the people in the most deprived areas also had a much lower uptake than people in the more affluent areas in East Sussex itself. So the data kind of followed what we expected. And then most interestingly, this slide, we actually created a map to show Hastings itself, because Hastings, as we showed, is the lowest uptake, and it is actually the most deprived area of East Sussex, looking at the 5 different areas. So we created this map, and it shows sort of index of multiple deprivation. So the darker the colour, the most deprived area, the lighter the colour, the least deprived area. And then we looked at the uptake within these areas in Hastings. And interestingly, the lower the uptake also matched with the more deprived area. So that was what we kind of would expect based on the research. But also interestingly, we mapped on where the vaccine sites were in Hastings. And the vaccine sites are here. There's 2 in these 2 areas here and 1 in Orr. And uptake was highest in Conquest and St Helens and Ashdown, where the vaccine sites were, and also in Orr, also where a vaccine site was. And interestingly, Orr is in one of those most 10 deprived areas in East Sussex. So it really highlighted to us that clearly deprivation is a reason for not getting the vaccine, uptake is lower, but when there's good access, like clearly here, where the vaccine site in Orr, the uptake is actually higher. So it was a key sort of target for us was to look at increasing access might then help improve uptake of the vaccine. So that sort of leads on to the action plan. So the first point was improving access to vaccines in those most deprived areas. So pop-up vaccine centres was a key approach. So we worked with the sort of Hastings Borough Council, community voluntary groups, and created a list of suitable sites for more vaccine centres in those more deprived areas. So looking at community centres, wellbeing hubs, sort of youth centres, food banks, working with the community. The Sussex CCG also put on a free transport scheme. So we kind of advertised that through flyer drops, sort of targeting the more deprived areas, say how you could get sort of a free bus or free taxi to your vaccine, and then targeting with leaflets to advertise people how to get the vaccine and how to get to their appointment. So just briefly, I think I'm running out of time. So briefly, just other kind of projects that we've been working on are sort of vaccine champions, so recruiting people to spread trusted messages through their own communities and sort of social media, targeting people from these more deprived areas and younger people. So community engagement programs with sort of, voluntary action groups, food banks, analysing the data weekly as it comes out, and then sort of targeted social media campaigns, communication campaigns, posters and leaflets like this one we've shown here, sort of grab a jab in Hastings, with examples of sort of local areas in community centres in the more deprived areas that people can get to more easily. So yeah, the data has shown, this is the most recent data I got from May, has shown that the uptake in these more deprived areas of Hastings has actually increased, and interesting as well, the gap has narrowed between the least deprived and the most deprived area. So in March, there was a significant gap between uptake of the vaccine, and it is starting to narrow. So hopefully through some of these targeted programs of more people in more deprived areas, the uptake of the vaccine is increasing. And it's just another graph to show, since the flyer drop and since more pop-up vaccination clinics, the uptake in sort of more deprived areas does seem to be increasing. Obviously, there's multiple factors involved. But yeah, that sort of ends the presentation. Now references. Thank you.
Thanks so much, Amy. That was brilliant. Obviously, I'm aware of some of the background about, you know, the reason, the different risk factors for vaccine hesitancy, and I was aware of social deprivation as one of the key factors. But I'd never really kind of framed it in the way that you've shown it there, which is if you actually put the vaccine sites where they need to be, there's much less of an issue. That actually makes much, I kind of made the connection in my brain that if you don't have transport, it's very, very difficult to get to them, isn't it? So,
exactly. Yeah.
It's a really, really obvious change to make, isn't it? Just put it on people's doorstep.
Exactly, and I think the map was just really good at just highlighting that, because you can see the connection between, if you're in a more deprived area, you may be sort of work hours that are less social, or you don't have a car, can't afford transport, so you're already kind of in a more difficult position of getting a vaccine. And then when the vaccine centres are also further away, it makes it even harder. So we were seeing how could we reduce the health inequalities by targeting people in deprived areas, and just quite a simple method such as just putting the vaccine centres closer to them. Just makes a simple solution to quite a complicated problem. Yeah, it's
brilliant. And I mean, it kind of makes sense with what's happened here in Manchester as well, because I remember when I got my vaccine, like the options that came up were all in very solidly middle class areas, you know, like in a health centre in a middle class area. And then later on, when they started to do the pop-ups, they'd obviously thought, well, we need to spread this out a bit more, so they were a lot more diverse in where they placed them, and that hopefully that will have increased the uptake rate, you know, uptake rate in the same way that you saw in your area.
Exactly. Yeah, definitely. That was really interesting.
Yeah, it's really interesting. Does anyone else have any other questions for Amy? Okay, well, if you do think of anything, please feel free to share them in the chat, and I'm sure Amy can respond. So thank you very much for that, Amy. So the next person, the next presenter is Edvaldo Bogorta from College University Logos, who's going to talk to us about COVID-19 isolation in Albania. So Edvaldo, I'll pass over to you.
Hello, everybody. Nice to meet you all. Yes, this is a study we started last year during the months of quarantine, and regards some ways to find the possibilities how to reduce the symptoms or the difficulties of the isolation that comes so quickly in the lives of everybody. So I'm going with the slides right now. Did the slides okay? Do you see the slide? Yeah, perfect. I'm not seeing that okay, but I'll try here. So it is a study by me, Irina Jafferi, a colleague from University of Elbasan, Leonida Utsai-Konari from University of Tirana, and Silvana Doci from University of Tirana. The background, as I said, is about the year 2020 that has been characterized also like this one, has been characterized for the worldwide problems, the worldwide pandemic situation from COVID-19 virus spread exponentially almost in every country. According to the World Health Organization, there has been many changes in daily life of people, including quarantine and isolation in order to prevent virus, modifying the lifestyle and the common attitude of living. Meanwhile, several studies highlighted the influence on economical status, social and psychological too. Recent studies evidence psychological consequences caused by forced quarantine and include sense of fear, frustration, depression, and depression. Meanwhile, it is recognized that exposure to either real or virtual natural environment helps coping with psychophysiological stress. It looks like the exposure to green spaces of nature is emotionally intense and leads to greater well-being. Moreover, the sense of awe itself seems to be related to people's perception of time, leading to the here and now condition of a healthy brain and to a successful process of decision-making. Considering the restorative potential of awe-evoke natural scenes, this study intended to investigate the need to counterbalance the psychological after effects of quarantine due to COVID epidemic. Additionally, such decision-making process was likely to go in favor of a sustainable environment too. The focus is on well-being in accordance to the World Health Organization definition of health, which is considered as a state of well-being rather than only the absence of disease. And this study aims to investigate people's psychological effects of exposure to mundane versus extraordinary nature during COVID-19 forced quarantine in Albania. We hypothesize that people exposed to awe-evoking nature reports would have a greater positive effect and less negative effects, more positive mood, willingness to make experiences rather than buying products, greater prosociality, as well as the willingness of voluntarily extending the quarantine in order to act in favor of the community. And we expected also that people exposed to awe-evoking nature report greater positive effect and less negative effect, as well as more positive mood compared to control group. All Albanian citizens more than 18 years were eligible to take part. The total sample was 68, but after the cleaning of the database, the final number was 52 because some of them were minors and others were people that doesn't reside in Albania. The questionnaire has been available in Albanian language. The study was conducted online in Albania using social media networks to distribute the questionnaire. This study was conducted using computer, internet-based tools to recruit via online the participant, and each individual session lasted about 30 minutes. Participants were allowed to terminate the survey at any time they desired, and the survey was anonymous and confidentiality of information was assured. Data were collected between May to October 2020 using an online questionnaire spread through the internet using the free Google Forms platform. For the data analyzing, we use the statistical problem SPSS version 22. Participants completed the demographic session of the questionnaire where they gave different information about age, gender, residence, where they live. Then to measure participants, just a second. Okay, maybe now it's not clear. Then to measure participants' psychological impact of quarantine, they completed the Center of Epidemiologic Studies depression scale. Then they conducted the first mood measurement, and the psychological impact of quarantine was measured as well as the depression. Participants were randomly assigned to either the awesome nature or natural slideshow condition. Participants were asked to watch each slideshow picture for at least 10 seconds before looking at the next picture. Immediately after the slideshow, we measured their emotion and the evaluation about the slideshow. Then participants proceeded with the second mood measurement, and in the following phase, participants completed a triple dominance questionnaire in order to measure their social value orientation. In the end, we measure also the willingness to extend their period of quarantine. Mood was assessed at the beginning of the experiment, and after the slideshow using 100-point scale ranging from 1 to 100. Emotion was regarding emotion. The questionnaire after the slideshow was measured the emotional impact, physical impact, and peak intensity of specific emotions: happiness, entertainment, amusement, calmness, sadness. Ethical approval was taken at the Ethical Committee of Logos University. This participation was voluntary and anonymous. An information sheet and the consent form has been used in order to provide participants with information and giving them the option to include in her data in the study or withdraw the data. In order to ensure privacy and confidentiality, subject's name was kept on a password-protected database and was linked only with a study identification number for this research. An information sheet and the consent form was used in order to provide participants with the necessary information and give them the option to include her data, as I said before. The study could be limited due to bias in self-reporting concerning self-rated behaviors and fear out of anonymity. The survey was completed, as I said, from 52 persons because 16 of them, the data wasn't correct. Description, as you see, regards the mean age that was 35.8 years old. Majority of respondents were women, 71%. Most of the sample came and were quarantined in central Albania, 84%. Most of them declared to be married, 53%, and not having a child, 57%. Also, 86% of participants were well educated. They had a university degree or a master's degree and a professional title. Since the aim of this study was to evaluate the impact of nature in mental health during the COVID-19 period, the participants were asked about their environment. So 32% of the interviews reported having a garden in their home. And of these, about 25% reported spending significant time in garden. Also, almost 40% of participants had a terrace at home. And of these, 30% have nature view from the terrace. Among 53% of participants had a natural view from the windows. And of these, 40% see often the view outside the window. The participants were asked about their symptoms related to the psychological stress, for example, anxiety, as they were exposed to the garden, terrace, or other natural interior elements. 77% of them were more than agreed to the fact that they experience a general decrease in this kind of symptoms. 17% were natural, and 15% didn't agree with this sentence. There was a relationship between the gender and psychological symptoms reduction. Almost 75% of female agree that experience a general decrease in symptoms related to psychological stress. And also 71% of participants agree that experience a general decrease in symptoms related to physical symptoms after being exposed to garden, terrace, or other natural interior elements. 13% among of them expressed neutral, and 15% didn't agree with this affirmation. Almost 78% of female participants agree that experience a general decrease in symptoms related to physical symptoms, while only 53% of male agree with this affirmation. According to the participants, 84% of them thought that exposure to nature through garden was the best factor that can help them in stress level reduction and leading to recovery. Also, we evaluated also the mood at the beginning of the experiment after the slideshow. Before the slideshow, the mean point was 68%, and the mean 68.8, and the mean after the next slide was 76.6. This means that contact with nature view improves the mood of individual. We ran a paired sample T to compare two means that were from the same individual, which resulted that there was a significant difference between the mood of the individual before and after nature images show in a 5% confidence level. That means that nature images slideshow affect positively the emotional state of individual, and also after the images, the respondents claimed that they felt more interested, more excited, more stronger, more enthusiastic, and prouder about living their situation, and they did not feel nervous, embarrassed, alarmed, scared, guilty, and sad. Regarding the Center for Epidemiologic Studies of Depression, respondents were asked to choose from 4 possible responses. The scoring of positive items was reversed, and the standard cutoff point of 16 or more was used to classify patients with depressive symptoms. For this sample, there was also the Cronbach alpha at 0.87, which indicates a high level of international consistency. The participants' depression scores range from 7 to 48, with a mean of 21.7. Also, 63% of the sample received scores above 16, which implied depression disorders. The patterns of score for each of the 20 items individually differ between age range of gender category, but this difference was not statistically significant. Respectively, the age categories that showed symptoms of depression were the category 18 to 28, 36%, that was the main one, while the least affected category was the age over 50 years old. Meanwhile, the category of women, 66%, show more depressive symptoms than men. We, after the analysis, we thought that there was a relationship. We pointed out a relationship between the gender and psychological symptoms reduction. There was a significant difference between the mood of the individual before and after the nature images show. It means that nature images slideshow affect positively the emotional state of individual, but there was no significant result about the depression symptoms. There were some results, but not significant. Considering the result about mood and well-being, it looks like that there are some restorative effects on people following exposure to slideshow pictures in order to cope with quarantine and isolation. This outcome is in accordance with White's, which emphasized the potential of using virtual nature. According to the results, people exposed to awe-evoked nature experience greater positive effects, more positive moods, and more positive moods. Furthermore, there were positive to voluntarily extend the quarantine in order to act in favor of the community. These were the final considerations we found out. If there are some questions.
Thanks so much, Edvaldo. That's great. One of my questions you kind of covered in the end of your presentation, but I was kind of going to ask about confounding factors. So you're showing these individuals the slideshows, the awe-inspiring nature, but then you've actually measured the confounder, which is the kind of their exposure to real nature. So they, if they have a garden, that has an effect, doesn't it? So I think from my perspective, this makes a lot of sense as a study, because we know that going out in nature is good for our mental health, don't we? And if there is a way that you can virtualize it that will have the same effect on people's brains, then that's amazing, isn't it? Especially in a situation where you literally can't go to the park or go to your local nature reserve. So I think it's really interesting. I think given that this is a small, you've got quite a small number, it's quite encouraging to see the effect that you've got. And it's not surprising that it's not that surprising really that your depression scores haven't gone, been significantly affected, given that the numbers are small. Yeah, but it's definitely interesting. And if looking at a slideshow of some photos can exhibit an effect, imagine if you could put someone in kind of an immersive 3D experience, you know, give them a virtual reality headset or whatever, where they're in a forest. That could be amazing.
Mm-hmm.
I think it's a really cool idea,
Yeah,
especially you know, especially where you literally aren't allowed to leave your house.
It would be very interesting if the number was higher, and also if we could split the sample to see how many people came from urban and rural zones. Maybe because, you know, in large cities is maybe difficult to find green spaces as much as in countryside. This could be another.
Yeah, I can see maybe there being more of an effect of your slideshow on people that lived in an urban environment compared to maybe those that are already living in a green environment. I don't know, that might not be true, but
They live
cool.
in cities, I think, yeah, most of them.
So yeah, thank you very much again, Edvald. That was really interesting. Yeah. If anyone else has got any other questions, now would be a good time. If not, then feel free to drop them in the chat. So our next speaker is Bernard. So are you? I think I saw Bernard joining during that last presentation. So if you could shout, Bernard, if you're on.
Yes, I'm on, James.
Hi.
Hi.
Yeah. So Bernard's going to talk to us about antimicrobial stewardship. I'm not going to read out your entire title, Bernard. I'll let you do the full introduction. But yeah, next presentation from Bernard. So go ahead, Bernard.
Okay, so I'll just share my screen now. Okay, so thank you very much, James, again for giving me the opportunity to present. So I'm going to discuss with you the findings of scoping review on antimicrobial stewardship and infection prevention interventions targeting C. diff and Klebsiella within healthcare settings. So infections have remained a leading cause of death over the centuries and indeed a public health priority. And various strategies have been used to treat infections until in the 19th and 20th century, when something interesting happens following the observations by Alexander Fleming on the effect of Penicillium mold on bacteria, birthing the era of anti-infective agents. And since then, antibiotics became the hallmark of treating infectious pathogens. But as they were gaining popularity globally, other issues began to emerge, and this included over-reliance, inappropriate use of antimicrobial agents, and the continued human-to-human transmission of pathogens because of breaches in infection prevention precautions, eventually leading to the emergence of antimicrobial resistance. And we have seen that since the early 2000s, there's been a 65% increase in the use of antimicrobial agents. And unfortunately, 50% of these uses are deemed as being inappropriate. And this is happening when at the same time, the rate of healthcare associated infections seems to be rising, 3.2 million infections and approximately 7,000 deaths are reported annually within the larger EU region, including the UK. Amongst some of the significant pathogens are the escape pathogens, which have been shown to cause significant harm and economic burden. And it's estimated that in 2050, about 10 million fatalities will occur due to these drug-resistant organisms. Although there are approaches to try and reduce antimicrobial resistance, the problem continues to persist. So in our scoping review, we focused on C. diff and Klebsiella pneumonia, C. diff being one of the leading causes of nosocomial diarrhea globally. and Klebsiella being top 3 leading cause of neonatal sepsis. And again, key amongst this type of bacteria is the extended spectrum beta-lactamase strains that have been shown to be resistant to carbapenems, which are some of the life-saving antibiotics that we have in our healthcare systems. Again, approximately 25% of patients appear to be or have been reported to have been colonized by either Klebsiella, and that's in the UK, in the US, in Australian hospitals. So the rate is quite high. And again, approximately 52% of these cases happen due as a result of patient-to-patient transmission. So as I did mention again, there is strong evidence to suggest that the antimicrobial stewardship and infection prevention interventions could be effective. And we've seen that they tend to target the behaviors of healthcare workers in terms of antimicrobial prescribing and infection prevention practices. However, when it comes to the application of behavior change principles in these interventions, there seems to be a huge gap, and it is our theory that, or our argument that potentially this could be one of the reasons that is contributing to the persistence of the problem that we face currently and in the future if we don't change the way we address the issue of antimicrobial resistance. So we wanted to assess the infection prevention and antimicrobial stewardship interventions targeting C. diff and Klebsiella. And we also wanted to describe the key outcomes for infection prevention and antimicrobial stewardship interventions. And lastly, our scoping review aimed at assessing the application of behavior change principles in these interventions within the healthcare settings. And so our approach was to undertake an initial scoping review in preparation for a more focused study, which we are currently in the process of doing following the findings of this scoping review. So we looked at different databases and to just try and retrieve articles on our topic of interest. And then we were really interested in healthcare facilities in terms of eligibility criteria for the studies. In the interventions that we were interested in were infection prevention and antimicrobial stewardship. In terms of outcomes, we are looking at changes in antimicrobial prescribing, compliance with the infection prevention guidance, and lastly was about the risk of C. diff and Klebsiella within the healthcare settings. And we looked at observational studies, quasi-experimental studies, and randomized controlled trials. In terms of data analysis, we followed a narrative synthesis approach for that. So we retrieved 34 articles, a large proportion of them from around the United States and Canada, and also a couple around the EU and the UK as well. In terms of the involvement of healthcare workers in antimicrobial stewardship and infection prevention interventions, this seems to be a very diverse group of healthcare professionals involved. But key amongst these are the nurses, the doctors, physicians, the pharmacists, and the microbiologists within this intervention. So these are some of the leading proportion of staff that are involved in those interventions. So we looked at our mapping of the interventions for targeting C. diff in regard to antimicrobial stewardship and infection prevention. What came out is that the focus appears to be around antimicrobial prescribing. So there is a lot about infectious disease consultations or microbiology consultations about appropriate antimicrobial agents to use, protocols and guidelines, antimicrobial audits and feedback to try and strengthen appropriate prescribing. However, we also have other interventions such as surveillance, screening, alerts and notifications, isolation precautions, care bundles, staff education, use of biocidal linen, and among some of those interventions. So we also try to look at to what extent these interventions applied behavior change principles. And what came out is that there seems to be a gap based on our finding in terms of the application of behavior change principle according to the theoretical domains framework proposed by Susan Michi and the behavior change will, in order for us to realize successful and sustainable behavior change, we need to focus on three elements, which are capability, opportunity, and motivation. So most of these interventions focused on capability, which just looked at maybe the skills of the healthcare workers, but in terms of creating opportunities for behavior change and trying to motivate the healthcare workers to adopt these desired behaviors, which is appropriate prescribing and compliance with infection prevention intervention, there appears to be a huge gap around that. In terms of the interventions targeting Klebsiella, so again, the same, basically the same list of interventions, but the only difference here is that the focus shifts away from appropriate prescribing more to the infection prevention practices around isolation precautions, contact precautions, care bundles, and but the list of interventions basically remains the same for Klebsiella as well. And again, with regard to the application of behavior change elements, we see again in terms of capability being the key aspect emphasized by these interventions, whereas opportunity and motivation seems to be ignored. So based on our mapping of the interventions, we have proposed the acronym ESCAPING interventions to denote the common interventions that the common infection prevention and antimicrobial stewardship interventions targeting C. diff and Klebsiella within the healthcare setting. So what's interesting is that these interventions also cut across the other members of the ESCAPE family as well, so could potentially be used to refer to generally all the interventions targeting the escape pathogens within the healthcare settings. And this, in summary, is education, surveillance systems, consultations with microbiologists and infectious disease specialists, audits and feedback, policies and protocols for prescribing, appropriate prescribing and appropriate treatments for infections, environmental measures, and then around cleaning of the environment. Then we've got bundles of care, isolation precautions and notifications, as well as alerts. In terms of the summary of the outcomes for C. diff interventions, based on their focus, which is mostly on antimicrobial or appropriate prescribing. So the key outcomes that we mapped out include antimicrobial use, cost of antibiotics, streamlined antimicrobials prescribing. Then we've got resistance threats, risk for healthcare associated infections, time-saving hospital stay, and adherence to isolation precaution. What I want to mention around this is that we saw one intervention that had the highest reduction in terms of antimicrobial prescribing, and that was an intervention that integrated the three elements of behavior change as outlined by Susan Nietzsche in the theoretical domain framework and the behavior change wheel. So quite something quite significant there, whereas those that just focus on the other elements, there tended to be some improvement in terms of appropriate prescribing and the other outcomes of interest, but the issue comes around sustainability of the long-term sustainability of those interventions. Some of them appear to have the effect of the interventions seems to have just lasted to the point of when the actual intervention stopped. Around the outcomes targeting Klebsiella in healthcare settings, again, similar outcomes, but here the key outcome seems to be around the risk for Klebsiella within the healthcare settings, and I think that's why there's a lot of emphasis around contact precautions and as well as the risk for other healthcare associated infections. There's also around antimicrobial use, but not being a key focus in most of the interventions that we looked at. And resistance rates, hospital stay, adherence to isolation precautions seems to be quite emphasized on. Our review considered antimicrobial stewardship interventions and infection prevention interventions in line with the core elements of antimicrobial stewardship as outlined by the Centers for Disease and Disease Control and Prevention. And we used the COMBI approach, which is the capability, opportunity, motivation, being some of the key elements that could potentially contribute to effective and sustainable behavior change. And so we use them to try and assess the application of behavior change principles in the AMS and infection prevention interventions. And our review primarily focused on C. diff and Klebsiella, so we did not go to focus on all the other organisms. But our current study now, we're looking at broadly the other organisms as well within the healthcare settings, and how behavior change principles appear to be key in long-term sustainability and the effectiveness of those interventions. So we mapped out the interventions, the interventions targeting C. diff, and have proposed the ESCAPE BIN acronym to denote these interventions. And so there appears to be a gap in terms of the application of behavior change principles in antimicrobial stewardship and infection prevention interventions. And we are currently trying to look further into that in terms of the underlying psychosocial factors that influence healthcare workers' behaviors. And towards the tail end, I think we'll be looking at an intervention just to try and a behavior-based intervention, trying to influence the underlying social cognitive factors rather than looking at the capability element only for infection prevention and antimicrobial stewardship interventions, and see how that impacts on healthcare associated infections and the behaviors of healthcare workers in the long run. Thank you very much, and I welcome any questions.
Thanks so much, Bernard. I've got one question. So it seems to me that common between C. diff and Klebsiella is that what you've found in this assessment is that there aren't really perceived gaps in knowledge for healthcare workers. It's more the gaps so there's not gaps in their capability or the opportunity to make the intervention. It's more that there are gaps in the motivation, which is why you're saying at in this final stage, working out what the more complex factors are that influence their ability to be motivated to actually undertake these changes. Is that what you're saying?
Yes. So the interventions that we currently have seem to focus more on the opportunity and the motivation element to try and promote successful behavior change. So our argument is that perhaps as the reason why there is they're not as effective, and that's why antimicrobial resistance continues to pose a threat. So we need to focus on the three elements as a unit rather than focusing on one. So yeah, so
is part of it kind of breaking the cycle of the idea that you apply the antibiotics, that's kind of the first line of defense, that's what you do, and not actually just saying, well, no, we draw a line under that, that's not the first option anymore. Is there resistance within a subset of workers that's what should, well, the way it's always been done, that's how it should be done? Is there some of that?
Yes, there's changing behaviors of healthcare workers is quite a huge and monumental task. So there are those who have practiced for a very long time, and there is that way they have always looked after their patients. So it's not really easy to try and shift their behaviors from what move them from what they know. It's like we are taking them to some unknown territory. So there's that kind of resistance, but hopefully as the information and the evidence continues to come out and be disseminated, that these other aspects are important in trying to protect us all from the burden of antimicrobial resistance, I think. Yeah,
it's really interesting. I particularly like your slide on the plethora of other interventions that are available. Like I haven't heard of the resistant sheets before. So the bedding that's microbial resistant. I've not seen that before. That's cool.
Oh, thank you very much, James.
So has anyone else got any other questions for Bernard before we move on? As always, if you think of anything you want to ask, please do drop it in the chat. So Alicia is a late addition to our schedule, and she's going to be talking about deconstructing the label hero. So without further ado, please go ahead and tell us about superhuman expectations, Alicia.
So first of all, can you hear me? Is my first question.
Yes,
okay.
We can hear. I can hear you anyway.
Okay, yeah, good. Okay, so can you all see the slides as well? Is that all? Perfect. Okay, great, cool. So yeah, hi. So my name is Alicia Maycock, and I'm an undergraduate from the University of Manchester. And I will be presenting my research on the label hero as applied to healthcare professionals during the COVID-19 pandemic. I'd really like to thank the organisers of the festival for allowing me to participate. So my inspiration to explore the label hero came when I called an NHS worker a hero myself. While they were grateful for my thanks, they quickly corrected me and told me that they didn't identify with this label. I then wondered how it must feel to see this label that you don't identify with plastered on absolutely everything, from billboards to newspapers to buses to house windows to shop windows to murals. Over the past several months, the national ritual of clap for key workers has slowly come to an end and been recognised as inappropriate. Increasingly, the same is happening with the label hero, but that said, it's still widely used, and so I still find it highly important to highlight some of the ways in which this label is damaging. So my research is ethnographic in style, and it combines digital participant observation on platforms such as Twitter and Instagram, and interviews with 3 healthcare professionals. My method was that I used hashtags such as hashtag NHS Heroes, #hero, and more broadly, #NHS, to filter out the posts and tweets related to my area of research. I then used these to inform my interview questions to understand how my interviewees related to the themes present. So overall, I found 5 key superhuman expectations that were suggested through the label hero. There are undoubtedly many more, but that lies beyond the parameters of my research and the restrictions I had, such as time and contacts. So to begin, so my first superhuman expectation was the idea that healthcare professionals do not feel negative or distressing feelings and emotions, such as fear, anger, or worry. So these were just some of the tweets that suggested this idea, despite having good intentions. So nothing can break our NHS heroes, made of steel, and our NHS heroes are always strong no matter what. Upon interrogating this theme with my interviewees, they said that the label hero certainly implies that we don't feel what the general population do, but we do. I feel scared and anxious every day. Just like people at home, I worry about whether I will get it, whether my family will get it, and I yearn for it to be over. And likewise, it certainly suggests that we don't suffer mentally, but that is wrong. The most annoying part is that I feel like I'm not allowed to feel worried or afraid. Like, that's abnormal, because that's not what heroes feel, is it? In this sense, the label hero, with its construction of a mythic figure, suggests that healthcare professionals do not bear or withstand. The label hero, through implying selfless fortitude and bravery, actually delegitimizes and ignores the suffering experienced by healthcare professionals. So, second of all, is the expectation of perfection, of having a 100% workplace success rate. So many tweets and posts that I found depicted healthcare professionals as godly and mythic in nature. For example, today's Greek gods, and our NHS heroes are perfect, angels from above. More directly and explicitly, some tweets actively voiced an expectation for healthcare professionals' work to be perfect, and a frustration when it wasn't. For example, on the left, wait, I thought we paid taxes so doctors could save lives. Death toll doesn't reflect hero behavior to me. Upon discussing this with my interviewees, they said that they felt that the label hero doesn't make room for the reality that doctors lose patients as well as save. One of my interviewees said, the label hero implies that death is the least common outcome, that we always heroically save people at the brink of death. Some of my interviewees also said that this expectation of perfection has heightened the feeling of guilt or moral injury that they've experienced, with one of my interviewees saying, I feel guilty for being unable to offer the care I would have wanted to give. I still feel the guilt 12 months later. Being called a hero doesn't help with that. It actually makes it worse. And likewise, there is certainly a feeling of, don't call me a hero because I'm not doing anything. I'm not curing them. I haven't been able to save my patients. In this sense, where the label hero implies and expects perfection, the healthcare professional in reality is likely suffering from guilt, exacerbated by the use and ubiquity of this label itself. So my third superhuman expectation regards healthcare professionals who haven't worked on the front line during the pandemic, perhaps because they haven't wanted to, or perhaps because they haven't been able to, due to having their own medical conditions that have meant they have had to self-isolate. Where the label hero has almost exclusively been used to describe healthcare professionals who work on the front line, does this make these healthcare professionals cowards? If heroes are extraordinarily resilient and selfless, are these healthcare workers weak and selfish? One tweet in particular read, struck up a conversation with somebody today in the wine aisle of Sainsbury's. Told me he was a doctor. Thought you're buying some Merlot, but why are you not out there fighting this thing? How many more of you are there lingering in wine aisles? One of my interviewees, who had actually for their own medical conditions had to shield and therefore wasn't redeployed onto the front line, said that they did feel that this cowardly image had been created of himself. However, that both himself and his colleagues didn't agree with it. My colleagues see me as human, a person, so I'm not a villain or an anti-hero in their eyes. But in the eyes of the public and politicians, this is what I feel like I have been viewed as. Here then, the label hero both asserts superhuman qualities of unbreakable mental toughness, but also suggests ostensibly cowardly qualities of fragility. So fourth is the suggestion from the label hero that healthcare workers don't need pay or protection, of course best seen by the laughable 1% pay rise. Since the start of the pandemic, superhuman and unphysical qualities of bravery and selflessness have been discussed so much that other material human requirements, needs and wants have been totally overlooked. They work with no protection and minimal pay. To be able to fight through this makes them this decade's heroes. Here, healthcare workers' lack of protection and pay appears almost glorified, acting as something that proves that they earned their hero title, perhaps speaking to a wider tendency of today's societal heroes to be those who give more than they receive. For example, firefighters, teachers, lecturers, and of course, doctors. Commenting on this theme, one of my interviewees said, "The label hero definitely suggests that we don't need pay or protection, but that is of course wrong. It's a bit distasteful to think that the reason you are being called a hero is because you aren't being adequately protected. And likewise, I would rather have never been called a hero and instead had the protection and pay I needed from the get-go." And lastly, there is a fine line between wanting to do your job and help people, but also having the protection and pay that allows you to do so. With the label hero, there is the implication that you will just do it anyway. So linked to this is the suggestion that healthcare professionals don't enter the profession for money, that in fact, they don't really desire it. One Twitter user wrote, "All heroes want to do is save and help. That is our NHS." While this is indeed true, it's not wholly true, the key word being all. They do want to help and they do want to save, but they also want pay and protection because they are human. Despite the fervency of their altruism, healthcare professionals expect to get paid because their work takes place in a world where everything has its price. Labeling them heroes simply tries to sanctify the act of simply doing their job and actually perpetuates the idea that their job is monetarily non-fungible. Yes, I want to help. Yes, I want to save people, but I want to get paid too. I need to get paid. And we aren't superheroes, we are people. We have human requirements that can only be met through money, just like everyone else. So lastly is the idea that healthcare professionals are responsible for their own physical and mental welfare. This expectation has both been achieved through the use of the label hero, but also the word resilience. We are so lucky to have our NHS heroes. They are so resilient. Heroes, angels, resilient, strong and brave, holding themselves and the world up. Commenting on the theme of resilience, my interviewee said, "Resilience assigns too much responsibility to the individual and not enough, if any, to the wider structures. If you ever raise a concern, perhaps related to the workload or feeling too much pressure, then often resilience will come in. Oh, well, you just need to be more resilient." Here then, resilience creates the idea that the system doesn't need to change. With an emphasis on perseverance and bouncing back, the reasons that resilience were needed initially are overlooked. Resilience thinking also encourages us to think about the idea of designing a future that's very much like the present, for a return to normalcy. However, this normal may not actually be desired. For example, one of my interviewees expressed a desire for a new and a different normal, with the quote reading, "The normal was not good enough for what the NHS is worth." In this sense, the simultaneous use of the words resilience and hero renders the system devoid of responsibility for its workers' welfare, and maintains the system through obscuring inherent faults, and also aims to depoliticize processes that are actually deeply political. So overall, the label hero assumes and expects healthcare workers to be totally mentally resilient and to have an infinite care capacity. It expects them to work to near perfection without adequate protection and pay. And through its creation of a heroic, sacrificial, and sacred aura around both their existence and work, it implies that they do not have human requirements, needs, and wants, such as those for pay, protection, safety, and good health of their own. When compounded with the word resilience, it also moves responsibility from the wider structures to the individual, acting as a mechanism to shirk and obscure governmental responsibility for healthcare workers' welfare. In line with research already conducted by Navaluri et al., my participants are calling for a change of vocabulary, to begin calling healthcare workers what they really are, workers, not heroes. The use of a label lexicon, they say, will immediately catalyse critical discussions regarding things such as occupational stress, pay, protection, health, and safety. It's now time to treat healthcare professionals what they really are, human beings, and to start meeting their expectations that are human, simple, and entirely necessary. Thank you for listening.
Thank you for presenting, Alicia. That was eye-opening. It's quite stark to see the viewpoints of practicing healthcare workers and how they feel about the titles that we've bestowed on them. I hadn't really thought about the negative impact that title could have. I think there's so many salient points you've raised there that I can't really cover even start to cover them. Things about the making sure that they're paid enough. Personal responsibility that's going on, all that that's going on at the moment with, we all have to take care of ourselves. So, well, it's, we're all kind of meant to look after each other, aren't we? I don't really want to get. I don't really have any specific questions about that other than to say that I really enjoyed that presentation. Thank you very much, Alicia.
That's okay, thank you.
I don't know if anyone else has got anything they want to ask Alicia, because Amy has got a question.
Yeah, partly just out of personal interest, because I'm a doctor myself and I've obviously worked in the pandemic. When you say healthcare professionals, was there a difference between kind of asking like nurses versus doctors versus say like auxiliary staff and cleaners and porters, or who did you ask by specifically? I guess I'm just interested to know.
Yeah, so it was, I mean, this is one of the limitations of my kind of research, because it was a small kind of group of people, but one was a palliative care doctor who had been redeployed to the pandemic, to the work on the front line. Another was an A&E doctor who had been partly redeployed, and one of my other participants was a GP who, for their own medical reasons, couldn't work on the front line. And I think that's actually kind of the point that you raised. I mean, like, I'm only in my second year of my undergraduate, so kind of going forward and going up into doing my dissertation next year, that's definitely something that I want to expand, is looking at this label, and especially militarized language generally in healthcare from different subject positions, because I imagine that there'll be populations of people who, this is brilliant, this is finally the time has come when we're actually being recognized as heroes, and this is what we feel we are. But yeah, it was, they were all kind of quite unanimous in terms of how they felt about the damaging effects that it had. But I definitely want to explore that particular area more.
Yeah, I think I was asking as well, because from my experiences, when you see kind of like cleaners and porters, I think they're the people that maybe are forgotten even more. And I'm sure they wouldn't call themselves heroes either, but in a way you feel like they are the heroes even more than the doctors and nurses, because they're the ones on the lowest salaries who put themselves at risk the most. But yeah, it'd be interesting to see how they feel from that title compared to how a doctor would feel or something. So
thanks, Amy, and thanks again, Alicia.
Can I just say, Alicia, there is a question for you in the chat if you want to just catch up with, I think it's from Eliza or Eliza. That's okay.
Was it product of an org?
Oh yeah. So I'll read it out just so everyone sees it. Do you know the origin of the label hero in this context? Was it the product of an organic process or that of a focus group?
If that's, yeah, I'd say, I mean, it felt like it was quite, in specific to the pandemic, I think it felt like it was quite, it kind of came out of nowhere, and obviously was kind of used, when it's used by kind of politicians, and it's used by kind of quite big voices in society, I think that it absolutely does catch on. But I think it was kind of at the beginning, no one really knew how to say thank you, I suppose. No one knew how to kind of show any form of gratitude, especially when you couldn't kind of be close to somebody. So you kind of think, what is it that I can do? Well, I can stand on my doorstep and I can clap, and I can, call somebody a hero. But then I think over time, it's like, well, actually, what does that do? I remember during the first lockdown, I was in a house in the middle of the countryside, and I was like banging a pot in a pan, and like, and it was just like, I was like, what am I at? Like, who? No one's hearing me. And I'm saying, like, how is this helping the people who are actually working? So yeah, I think it was perhaps almost like a bit of a panic move at the beginning. It's like, how do we say thank you? What can we do? But I definitely think it's had different usages throughout the pandemic, definitely.
Yeah, I think that's really, it's like, I think it was kind of almost, yeah, like you say, Alicia, it was like almost kind of a reaction to the strangeness of the situation. And then also with the social media, once something gets taken in, once something becomes part of the lexicon, it just gets perpetuated then, doesn't it? And then you see murals saying hero and adverts, and if the politicians use the term as well, then
I think that's I think when the politicians, interesting, my participants kind of said that when politicians started using it, that's when they became really quite resentful. With the public, there was an understanding of, okay, well, actually, you can't do much. You can do what we ask of you, social distance, hand sanitize. But when politicians started using it, it was, well, you actually can do something, and you're just standing on your doorstep and clapping and calling me a hero. And I think in that sense, when politicians started using it, that it had a different meaning, and it felt quite sinister, I think, for my participants.
Yeah, it's a really interesting discussion point anyway, and best of luck with your future studies and into digging into it in more detail. Okay, so you might have noticed that we're running a bit short because we were down to presenters. So I'm not sure what their explanations are, but not to worry. It just means we finished a little bit early today. So it remains for me to say thank you very much to all our presenters. As I've said in chat, I've learned a lot today. We've had some really interesting discussions. As I mentioned early on, this presentation is this whole session is being recorded, so I'll get it all sorted this evening. It'll probably go onto the program website at some point tomorrow, so you can go back and look at any of the talks or discussions we've had. Thank you all for attending. I hope you've all enjoyed it. I certainly have, and maybe see you at some of the other sessions later in the week. Take care, everyone, and hopefully see you soon.